thanks so much for joining me to talk about your latest research. So can you first off just give us a little introduction to who you are and your backgrounds?
Thanks, Kate. I'm Liz Stokes, a senior researcher in the Health Economics Research Centre at the University of Oxford. I'm a health economist, so I work on economic evaluations of new interventions and new ways of working, assessing their cost effectiveness. So we look at costs and outcomes of new interventions and assess their value for money.
Great.
I've been in Oxford since November 2009. I come from a maths background, but started working in health services research and then predominantly with a health economist. I've got a master's in medical statistics and then I've done a PhD in health economics.
Great, thanks. And Chris?
I'm a research director here at Big Health, and my focus is on real-world evidence. And I've been here at Big Health for almost 5 years now. And before that time, I did a PhD in behavioural management of insomnia on sleep restriction therapy. And I did a postdoc at the Woolcock Institute at the University of Sydney as well. And then since that time, I've been working mostly recently on the evidence base for digital therapeutics for Sleepio, for insomnia. And we have a new treatment called Daylight for generalized anxiety disorder. So I've helped to establish the evidence base for that product as well. And nowadays, we're focused on making sure that our products are not only safe and effective, but they can help treat folks and they have a health economic benefit as well. So we're looking to establish the cost and the benefit to our products. And that's why we have partnered with folks like Liz at the University of Oxford, where we have done this type of research that we'll describe today.
Great. Well, yeah, that leads us in nicely to the work you're going to talk to us about, which is looking at, so I'm going to get this right, the quality adjusted life years for people with insomnia having digital CBTI. So first off, for those of us that are not quite so good on the health economics, can you just tell us quickly sort of what are quality adjusted life years? What's that looking at? What can that tell us?
Yeah, so a quality adjusted life year combines both length of life and quality of life into a single measure. So 1 year in full health is one QALY, and 2 years in half health is also one QALY.
Okay.
And the idea behind this is really that some interventions, if we think across the NHS or healthcare more generally, some interventions improve length of life, whereas others increase quality of life. So it's important to capture both things. So QALYs are often used as the outcome measure in economic evaluations. And I guess their particular strength is that they're an outcome measure that can be used across a broad range of disease areas and patient groups. So it's really useful for bodies like the UK National Institute for Health and Care Excellence, NICE, because they can compare sort of value for money of different treatments across the whole spectrum. So they're really helping us to look at value for money and judge whether a treatment is worth the cost.
Perfect. So this then is based on data from the DIALS trial, am I right? So Chris, I think you're going to tell us a little bit about what you did in that study and sort of what you were looking at.
Yeah, of course. And so the DIALS trial was really an evaluation to help understand whether a digital therapeutic, an automated digital therapeutic for insomnia management, Sleepio, would be effective across a range of individuals for outcomes that were not specific to sleep. So as we all know, insomnia is a 24-hour disorder, and it affects, not just nighttime symptoms, it also affects the daytime performance as well. And so the evaluation of the DIALS trial was to establish whether or not Sleepio can help with some of the things that folks feel during the daytime. And we measured things like psychological well-being, for example, as one of the co-primary outcomes. Another one was the sleep-related impact of the insomnia on that person's attributions of daytime functioning. And then the last one was their functional health as well, which is really important for measuring QALYs. So with these measures, we realized that we could perhaps use the functional health measure in the DIALS trial to evaluate QALYs, because it was assessed using the PROMIS-10, which is a standardized measure of functional health. And then we could use that measure to then develop the QALYs estimation from that study, which wasn't previously done in the original report. So that's what we intended to do. And a little bit more background about the DIALS study. It was really important because we sampled folks from the UK, the USA, and Australia. So it's a large study of over 100 people that were randomized. So it is really an effectiveness type study, and that makes it more generalizable across different patient populations as well. So a little bit more representative than, you know, a normal efficacy trial would be as an effectiveness trial. So I think it's good in that way as well. We did have some good follow-up data that extended out to 48 weeks in the folks who received Sleepio. So folks were either randomized to receive Sleepio or sleep hygiene intervention control, which was basically what they would receive if they went to their doctor in the UK with an insomnia complaint. So about 80% of the time, or a little bit higher than that, they would receive this sleep hygiene advice, and that would be the treatment as usual, so to speak. So we wanted to test whether it would be more effective Sleepio than the standard of care.
Great. Well, so that leads us on to the findings. What did you guys find?
So the main finding was that the EQ5D scores were higher in the Sleepio group at all time points after baseline. And that then resulted in statistically significant QALY gains to 24 weeks and to 48 weeks compared to the sleep hygiene control. So Sleepio was associated with statistically significant gains in QALYs over time compared to the control. Chris, do you want to say something about the sort of insomnia results?
Yeah, sure. Well, the insomnia outcome really was a secondary outcome because it wasn't the main outcome of the study. But what we do find is that there was improvements in insomnia too, measured by the sleep condition indicator. And what that found was, when we looked into the mediation analysis of the trial, was that the improvements in sleep helped to explain the improvements in these other areas that were improved as well, these more, you know, functional health measures and psychological well-being as well.
Fantastic. So from reading the paper, the sort of take home in terms of the QALYs is that there's a 9.5 days in perfect health. So could you try and just put that into a little bit of context for us? Like, how does that relate to other types of interventions, and kind of what does that mean, sort of perhaps in a bit of a broader setting?
Yeah, so it's quite difficult. It's difficult in some respects to say. There's no set sort of minimum clinically important difference for QALYs. So I think there's a couple of things I would say. 9.5 days doesn't sound huge, but I'm sure if you ask patients, they'd rather have it than not have it. And I think as an economist, I'm weighing up the inputs and outputs. So it's maybe not a huge gain in QALYs, but Sleepio is also a low-cost intervention, so it's likely to be cost-effective. So that was the other way I would look at it. And of course, these were the benefits up to 48 weeks, but benefits may continue longer than that, so may in fact be larger.
Yeah. So then, sort of, I guess, just to wrap things up, what's the sort of next step with this kind of research?
Well, these type of evaluations are really important for payer decisions. And so within the UK, for example, having a cost assessment and a QALY evaluated in this way helps us to understand what the cost benefit would be if it was applied to a full wider national reimbursement strategy as part of the NHS, for example. And so we will be speaking with decision makers about this result, and this will hopefully help with the uptake of Sleepio in healthcare-based systems. So hopefully, you know, we could do other research like this on other products such as Daylight. And yeah, it's really a kind of first step, I would say, on trying to understand what is the cost benefit from a treatment perspective relative to other forms of care that are currently being received today in the NHS, for example.
Great. Well, good luck with all of that. So thanks so much for talking to us. And obviously people can read the paper to get the full details of what you've looked at.
Thank you, Kate.
Thanks.
Thanks, Liz.